So I divided chapter 12 up into a few different PowerPoints, a couple different PowerPoints, and we divided the content up into, at least for right now, 3 days of content. So this is going to be what we talk about from chapter 12 for the first day. So it's not going to go exactly in line with the book chapter. So just realize that if I were you, I would focus on the specific sections of the chapter that are mentioned here. So for this first part, we're going to talk about secondary survey, vital signs, and crutch fitting as well as cane fitting. So this is the treatment algorithm that's mentioned in the chapter. And as you can see just by looking at it, so you have the injury, you conduct a primary survey, which we'll talk about in a different PowerPoint, to assess kind of their level of consciousness. And then if you have a conscious patient, you can move straight into your secondary survey, which mainly means that they are stabilized to the point that you can ask some questions, take some vital signs, and try and figure out what your treatment decisions are going to be from there, and then get them off of the field or off of the court or wherever you're at, and on the sidelines and in the athletic training room, to a hospital, whatever it is that you have to do. So for the secondary survey, that's basically what you're doing. You've already figured out that your patient doesn't have any life-threatening conditions. You've addressed any significant bleeding, if there is any, and so they are what we would call stable. And so from this point, you can go on to kind of assessing their vital signs. If they're stable every 15 minutes, if you start to see changes, then that kind of decreases from there, and you may have to assess more often. So when we talk about vital signs, some of the specifics that I just want to kind of remind you, hopefully this will be a review from when you took first aid and CPR. But when we talk about vital signs, one of the first ones that you'll have to do is take a pulse. And just as kind of a refresher, if the pulse is rapid and weak, then it could mean that the patient's suffering from shock. Obviously, if you don't know any different, it could be a diabetic coma. If you know that they don't have diabetes, not going to be an issue. Heat exhaustion, if it's rapid and strong, then it could be that they're scared. Which is pretty common for an injury. It could be something more significant is going on, like heat stroke. And if their pulse is slow but strong, it could be a cerebral stroke or indicative of some sort of skull fracture. When we talk about state of consciousness from an EMS standpoint, there's a variety of different ways that you can assess it, but the AVPU scale is an easy way. So are they alert? Can they talk to you? Can they answer questions? Do they respond to your voice? If you can't, at this point you've already determined that they're conscious, but you can still kind of say, yeah, they respond to my voice. They kind of moan or groan, even if they're not alert enough to answer questions. If you are shouting at them, are they, moving around? The next level would be, if they're not alert, if they can't talk to you, if they don't respond to your voice, do they respond to pain? And we usually call that a sternal rub. So you would just kind of take your fist and rub it up and down their sternum and see if you get a response that way. And then the last portion of the AVPU scale is unresponsive. So even though they're considered stable, it could be, ideally they're alert, but it could be that they kind of go down the scale, so to speak, as time goes on. So it's another good reason why you want to make sure to monitor them. Respiration, so their breathing. Remember that breathing is, for normal adults, is 12 to 22 breaths per minute. So you just kind of want to pay attention to, are they breathing too fast? Are they breathing too slow? And then make any adjustments from there in terms of giving them supplemental oxygen or making a note of it or whatever is appropriate for you to do. Checking blood pressure is also a good thing to keep track of, and just kind of noting, is it going up? Is it going down? because that could mean a few different things. Temperature, especially if you're talking about environmental issues, are they too hot? Are they too cold? Are they comfortable? Even if you don't have, means, if it's not appropriate to do specific types of thermometry like rectal thermometry, you still want to kind of take note of what their temperature is. Skin color can also tell you a lot. So is their skin red? Are they getting good blood flow? Are they sweaty? Is their skin blue, meaning maybe they could be becoming cyanotic? Is their skin gray or kind of ashen colored, which can sometimes mean that they're losing blood? So noting their skin color. And their pupil reaction to light. So if their pupils are constricted, and this is something that you may notice just by looking at their pupils, but will definitely become evident if you are using a pen light. But pupil reaction, so are their pupils constricted? That can indicate that they're on some sort of depressant drug. Are their pupils extremely dilated? That could be indicative that they're on some kind of stimulant. It could mean that they have head injury of some sort, or it could mean that they are going into shock. And then accommodation, which we'll talk about in class, kind of has to do with if you take your pen light and you move it kind of toward their nose, then both eyes should move toward the pen light together at the same time to accommodate for that change in movement of the pen light. And so if both pupils do not do that, both eyes do not do that, it could also be indicative of a brain injury or some sort of extensive alcohol use, or even alcohol or drug poisoning. So movement isn't necessarily a vital sign, but it's important to note, are they able to move their arms and legs or not, for example, or do they complain about abnormal nerve responses like numbness or tingling? This could be indicative of a C-spine injury, so it's just something to keep in mind. Again, we're talking about on the field, but even when you get them off of the field, when you're continuing to assess, just making notes of, are there any kind of deficits in their sensation or in their reflexes or things like that. So for moving and transporting the patient, the biggest thing about this when you're going from on the field to off the field is that you want to try to do it, and this sounds pretty obvious, but you want to try to do it and make sure that it's not going to result in any kind of additional injury. So there's a few different techniques that we use. One of them is just giving them ambulatory aid. So assuming that they're on the ground, you want to gradually, once you've determined that it's okay to move them and it's safe to move them from there, you want to gradually get them from a supine to a seated position and then kind of wait a few seconds, let them get their bearings a little bit, make sure it doesn't affect their blood pressure too much, and then move them from seated to standing. Ideally, you want to have 2 people to do this. That doesn't always happen, but it's a good idea to try to get 2 people to kind of help out with this. If you are by yourself, then my suggestion is that you stand and you try to get them up from their, standing on their uninjured side. So in the picture, if the right knee is the injured knee or the right leg is the injured leg, then if you're by yourself, you want to try to stand on their left side. You can also do manual conveyance. So if they're not strong enough to walk off the field by themselves, but you know that you don't, it's not significant enough to need EMS to come get them, then, you can have kind of the 2-arm seated carry, which you can see in the picture where you've got, again, 2 people that are kind of interlocking their arms underneath the thighs and then having the patient wrap their arms around you and kind of carrying them off that way. So those are just 2 pretty basic, pretty common techniques. And then the last thing to talk about for this section is use of crutch or cane fitting, and it's easier to do this in person, so I'm not going to spend too much time on this, but basically you want to make sure that the crutches fit comfortably and that they are not cutting off blood flow to the axilla, and also that their elbow is in slight flexion, again, just to kind of take pressure off. And then with a cane, you want to measure from the ground to the height of their greater trochanter. And then when it comes to walking, crutch walking is kind of, similar to regular walking in the sense that, the crutches are kind of taking the place of the weight of both legs. So if they cannot weight bear at all, if they're non-weight bearing, then we usually use a tripod method, which again we'll show you in class. Eventually hopefully they'll get to the point where they can do some touchdown weight bearing or weight bearing with toe touches, move to partial weight bearing, and then move to full weight bearing. Stairs for up with the good and down with the bad mainly means that when you come to a set of stairs, you want them to put their good foot up first, and then up with the crutches. And then when they're coming to go down the stairs, they're going to put their crutches and the uninjured foot, or excuse me, the crutches and the injured foot down first, and then step down. And then cane walking or a single crutch, like I mentioned before, when you're transporting somebody, it's almost like you are acting as the crutch or the cane. If they are walking with a cane or walking with a single crutch, then you are going to provide the support on their unaffected side.